Thank you to the organizers for inviting me to speak today. And today I'm going to be talking about how we used a previously developed model that some of you have probably seen before to understand when is the optimal time to administer docetaxel in metastatic prostate cancer patients who are receiving hormone therapy. So let's begin. So prostate cancer, it affects 1 in 9 American men, and unfortunately 1 in 41 will die from it. And typically these patients, they might start off as, they have an initial rise in their tumor burden, and at that point they would receive some type of local therapy. So local therapy in this case would be a prostatectomy or radiation treatment. After that time, then they have an increase in their tumor burden again, and at that point they start on hormone therapy. Now, hormone therapy, the typical one that we have been using for the past 70 years has been androgen deprivation therapy. It's been the mainstay treatment, and patients typically receive this either until developing resistance to ADT or and still continue on with chemotherapy, or they can receive it and then receive second-line hormone therapy, which is abiraterone, which is what Dr. Gatenby spoke about earlier in the day. So the median survival in metastatic prostate cancer patients receiving ADT is about 3 years. So you can see here in the schematic here that they typically go from asymptomatic to symptomatic, and at some point they go from non-metastatic to metastatic. So once they're in this metastatic regime, and they're receiving ADT, they will, they may die after about 3 years. So we want to see how can we optimize this treatment in this area, in this metastatic regime. So for that, these patients, they also go from a castrate-sensitive to castrate-resistant setting. And what that means is castration-sensitive means that they're responding to hormone therapy, they're responding to ADT, and then they go on to castrate resistance where they're no longer responding to it and they might need something else. So and that is where chemotherapy comes into play. Chemotherapy now, the question is, when is the optimal time to give it? Should we wait until these patients develop resistance to ADT and then give chemotherapy with ADT, or should we give it up front? So here's the question. If we were to give it earlier, prior to the development of castrate-resistant disease, would that be more beneficial for a specific patient? Okay. Now this has been studied in 2 settings. So as I mentioned before, castration sensitive, where they were still responding to hormone therapy. This was done by Sweeney et al. And in this one, they are comparing ADT plus docetaxel, so ADT plus chemo, versus ADT alone in the hormone sensitive setting. And what they found was that giving chemotherapy before they developed resistance to ADT extended survival by 13 months, okay, when compared to ADT alone. Now, in the castrate-resistant setting, in these patients, they have developed resistance to ADT, and at that point, they're put on ADT plus chemotherapy. And in this case, we could see that adding in docetaxel, though it extended survival by a little bit, it was only by 2.4 months. So there seems to be a sweet spot for specific patients where if you give it early, you might get a benefit of up to 13 months, as I previously mentioned. But if you wait too long until they actually develop resistance to ADT, that might be too long to wait. And at that point, they're no longer responding. Giving docetaxel or giving chemotherapy at that point is not going to give them much of a benefit. The question is 2.4 months really enough for some patients? For some patients, that might mean, attending their daughter's wedding or, spending some extra time with family. But for others, they might need more than this 2.4 months. So we want to see what is the optimal time to administer chemotherapy, and is this patient dependent? So to investigate that, we're looking at the biomarker prostate-specific antigen. Prostate-specific antigen is measured in the blood of these patients. It's a non-invasive marker, and we have data from our collaborator, Dr. Tian Zhang at Duke University, and she sent us data for 2 sets of patients. So castration-resistant patients where they received ADT up front, followed by ADT plus chemo after developing resistance to ADT. And then in the castration-naive setting, where these patients received chemo and ADT from the very beginning. So we have patient data for 38 patients in the castration-resistant setting and 56 patients in the castration-naive setting. And here's just a swimmer's plot of the two data sets for each of the patients. The gray is showing when they're on combination therapy, and the white is showing when they are on ADT alone. So for some of the castration-resistant patients, you can see here, we also had some follow-up data. So after they received their up to 10 cycles of chemotherapy, then they continued on to ADT, and we had some follow-up data for those patients. Okay. So now that we have our biomarker, we're going to develop a mathematical model. The mathematical model I mentioned from the beginning was an extension of a previously developed model that we used to study intermittent therapy, intermittent hormone therapy in biochemical recurrent prostate cancer patients. So the model is based on a stem cell hypothesis. So in the stem cell hypothesis, it says that the intact prostate, these basal cells, they can self-renew, and they can also go on to produce these secretory cells that go on to produce PSA, which is our marker that we have in this case. Now, in the castrate prostate, where they have decreased androgen, this was done in an experiment by Kofi and Isaacs back in 1989, and they realized, or they noticed, that when they deprived the prostate of androgens, what they found was that the prostate completely shrunk. But then once that androgen was restored, then the prostate it grew back to its original size. So instead of just saying, these are just basal and secretory cells, now we can instead say that these are perhaps stem cells. So the stem cells can self-renew. They can become these transit amplifying cells. And once they have enough androgen, then they are able to produce these differentiated cells, which go on to produce PSA. Now, some of the properties of stem cells, they have longevity. As I mentioned before, they can differentiate. They have this unlimited self-renewal, and they are highly invasive. So we think that this might be a route to go in terms of modeling it. So the model that we have is a stem cell model, as I mentioned before. So we have the stem cells. They can divide symmetrically or asymmetrically. Symmetric division produces 2 stem cells. Asymmetric division produces 1 stem and 1 differentiated cell. The differentiated cells are the ones that respond to hormone therapy, and they also go on to produce PSA. Now, with chemotherapy can attack both the stem cells and the differentiated cells. So you can see here that we have a decay term here on the stem cells and on the differentiated cell compartment. That is the main difference between the previously developed model and this model. So in the previously developed model, it was intermittent hormone therapy only, so we didn't have any chemotherapy at all. But now we know that adding in chemotherapy, we have this decay term on both of the compartments. So mathematically, we just have that the stem cells, as I mentioned before, they can self-renew. They self-renew at probability PS. They divide at rate lambda, and they die when treatment is turned on. So this TXD is just a Kronecker delta function where it's equal to 1 when treatment is on, and it's equal to 0 when treatment is off. The differentiated cells are modeled in a similar fashion, except that now we have a decay term from ADT or from hormone therapy, and then we also have this decay term when chemotherapy is on. And similar to the TXD, the TX is just now denoting when ADT is on. So again, it'll be 1 when ADT is on and 0 when it is off. And then PSA is produced by the differentiated cells at rate rho, and it decays at rate phi. Okay, so it's a very simple model. We went from 5 parameters up to 7 parameters, and we are going to calibrate this model to our clinical data and then run some simulations to determine when is the optimal time to administer this therapy. So the model calibration is here. So we have, as I mentioned before, 2 data sets, castration-resistant and castration-naive. In the castration-resistant setting, we have that the patients are receiving ADT alone. So that is here. They receive ADT up front. And then once they develop resistance to ADT, they receive chemotherapy for up to 10 cycles. In this case, this patient only received 8 cycles of chemotherapy. And as I previously mentioned, ADT is still on. Despite them developing resistance at this point, they're still receiving ADT, but now they're just adding in chemotherapy. And then once they finish their chemotherapy, then they continue to receive ADT alone until resistance. In this case, this was just the last data point that we had for this patient. This was not resistance in this case. But you can see that the difference between ADT and chemotherapy is that when ADT is on, the stem cells are being selected. So we have a competitive release of the stem cell population. And in that case, we're thinking of that as a resistant population, resistant at least to ADT. When chemotherapy is turned on, we have a decline in our stem cell population. And then we turn chemo off, and now we have, again, a rise in the stem cell population. That's in the castration-resistant setting. In the castration-naive patient, this is patient 109, and this patient, he received 6 cycles of chemotherapy with ADT upfront, and then after that, they received ADT alone. And you can see if we would just compare the extent of the decay in the castration-resistant patient versus the castration-naive, this patient didn't have so much of a decline in their stem cell population, though it was there compared to when it's not on at all. So these are patient-specific fits where we have, said we had 7 parameters, and here we have 5 patient-specific parameters. Okay. So now the next thing, now that we've calibrated the model and we're satisfied with the fits, we believe that the model is able to accurately describe both of the dynamics in both of the patient groups. Now we want to go on to simulate different timing of docetaxel to determine when is the right time to give it. So for that, here is one patient, patient 148, and this patient was a castration-resistant patient. So you can see here they received ADT alone, and then when he developed resistance to that, then he got chemotherapy for 4 cycles here, or 3 cycles. Now, again, we've calibrated, we have our parameter values for this patient. We can now use them to say, okay, what if we were to give them chemotherapy earlier? What would happen? So when we do that now, the gray curve is showing when we give it early. Now we're giving 6 cycles of chemotherapy up front, and then we're allowing PSA to grow until resistance. And in this case, when we compare the time to progression between the late, which is the black, versus the early, which is the gray, you can see that this patient would benefit from an earlier administration of chemotherapy. So that goes back to the original hypothesis from these previous studies where they're saying that, you know, adding it in after the development of castration-resistant disease is only going to extend it by 2.5 months. So maybe we might need to give it earlier. In this patient, you can see that giving it earlier, there is a benefit. Now, on the other side, we have a castration-naive patient. This was a patient who received chemotherapy from the very beginning. As you can see, the model is able to fit the chemodynamics, chemo plus ADT dynamics. And we should notice that this patient had a much lower PSA to begin with. So it might imply that perhaps giving chemotherapy at this point might not be as beneficial as it would be when you're giving it at a later time. But when we run this early versus late, again, we see that when we compare the time to resistance or time to progression between the early and late administration for these patients, for this patient, again, we have that early administration is better than late. Now, it's not always like that, so I'll show you 2 more patients where it's the opposite. So for each of these patients, patient 121 and patient 104, patient 121 was a castration-resistant patient, so he received chemotherapy late. And when we simulate chemotherapy earlier, we have that they progressed a lot earlier than if he was to continue on. So in this case, he received chemotherapy plus ADT. We have a decline in his PSA, and then we simulate ADT alone, and he developed resistance around day 575. Whereas if we were to give chemotherapy plus ADT up front and then followed by ADT alone, he would develop resistance around 450 days. Similarly, for a castration-resistant patient, now we have that they received chemotherapy up front, chemo plus ADT up front, and then we simulated ADT alone. They would develop resistance after about 700 days. But if we give it later on instead, so, ADT alone followed by chemo plus ADT and then ADT alone, we would be able to extend survival in this patient. So as you can see here in these two patients, early is worse than late. So you can tell from the previous patients that I showed versus these ones that the early versus late argument is definitely patient specific. So the main takeaways for this part is just that the optimal chemotherapy timing is patient specific. And from the previous model that I mentioned in the intermittent hormone therapy study, the stem cell self-renewal rate was the main driver of resistance. So we noticed that when we compared the continuous responders versus the resistant patients had a significantly higher stem cell self-renewal rate when compared to the responsive patients. So the question now is, does this separate patients who need chemo early versus late in this model? Because in this model, we still have the same stem cell self-renewal rate. So it might mean that the patients who might need chemotherapy early have a higher stem cell self-renewal rate. So we need to deplete that population earlier rather than wait for it to continue to grow later on. So the question now is, how can we learn this? Can we learn this from early on? So for this patient here, this is one of the next steps that I would like to work on, is to determine if we can use early ADT dynamics. So this is going to only really be in the castrate-resistant patients, because the castrate-naive patients are receiving ADT plus chemo from the very beginning. So for the castration-resistant patients now, can we use early ADT dynamics to determine when is the optimal time? So that might mean fitting the model over the first 4 data points, or 5 or 6, etc. Fitting it over the early data points and then simulating chemotherapy early or late. So in this case, we would fit over the 4 data points and then continue to simulate ADT and then add chemotherapy at another point, or add it from the very beginning and see if there's a difference. And that might tell us what patients fall into what group, what patients need early versus late. And we can extend this 4 data points, we can do it for 6, we can do it for 7, and determine when is the time, when do we have enough data to tell a patient you definitely need chemotherapy at this point or you need it at a later point. So these are some of the next steps. So in summary, as I mentioned before, we've extended the stem cell model to investigate the optimal time to administer chemotherapy after hormone therapy. The model can accurately describe PSA dynamics in both the early and late chemo settings. And the model simulations of the early versus late, it implies that the timing may be patient specific, but it may be best, I hypothesize that it may be best to give prior to the development of castrate-resistant prostate cancer. And that mainly goes back to the prior study where waiting until they develop CRPC only extended by 2.4 months. So on that, I'd just like to acknowledge the Enderling Lab, my PI, some of our collaborators, Dr. Gatenby and Dr. Jinzong Zhang. They were gracious enough to share some of the intermittent ABI data with us, and Dr. Gatenby has been instrumental in this study as well. And then Dr. Zhang and Dr. Wang at UNC and Duke for their assistance as well. So at this time, I'll take any questions.
Thank you very much for a very inspiring talk. And we indeed have some questions. First question is from Daniel Glazer. And it says, hello, Renee. What was the reason for the decision not to include transit amplifying cells in your model? Was it for the sake of simplicity or, for example, limited data? Mm-hmm. What dynamics might or might not be missed in the exclusion of transit amplifying cells?
That's a good question, Daniel. Thank you for your question. So for the simplicity of the model, and based on the fact that we were able to develop a pretty predictive model from the very beginning with just the stem and the differentiated cell population, I would say it was best just to not include that subpopulation at this time. We also don't have data to calibrate either one of them, the stem or the differentiated. So adding in another compartment, I don't think it would necessarily add anything to the study at this point.
Okay, then we have a next question from Fred Adler. And he says, fascinating talk. Maybe I didn't read it right, but it looked like the probability of symmetric division is increasing in the fraction of S cells. This will create an Ali effect in stem cells and seems kind of backwards to me. Are the results sensitive to the choice of form of this feedback?
The form, I don't think I understand his question.
Yeah, so it looked like that the probability of symmetric division is increasing in the fraction of the S cells, so the stem cells.
Mm-hmm. That's correct. So the stem cells, the growth of the stem cells is dependent on that PS rate. So I mentioned before, and I should have shown it here from the previous study, the resistant patients in the previous study had a significantly larger stem cell self-renewal rate, the PS value. So that is that, because we're thinking of the stem cell population as the resistant population. So if you have a higher stem cell self-renewal rate, you have more resistant cells, you're going to develop progression earlier. As opposed to having a lower PS value.
Okay, so he's right that it will lead to Ali effect, actually.
Yes.
Mm-hmm. Okay. Good. Maybe you can discuss this further.
Yeah.
Then Maximilian Strobo is saying, great talk, Renee. What is the mechanism in the model that makes early chemo be better, worse than actually late chemo?
Mm-hmm. So that's what I want to investigate next, because I think it's definitely patient specific. When I looked at just analyzing the parameters up front, I'm not seeing a clear differentiation between early versus late. Sorry, not early versus late, but patients who would benefit from chemo earlier versus later in any of the parameter values right now. So I'm looking a little bit more into it, maybe going back to the model calibration. I think I might have too many parameter values right now. So if I can reduce that in some way, then I might be able to see the differentiation between the two to determine what's driving, early versus late. So that's just the next step.
Mm-hmm. Okay, the next question is from Thomas Hillen, and he's saying, hi Renee, is it possible to biopsy the tumor and see if a castrate-resistant population is already there?
I would love to. That would be ideal. So unfortunately, we don't have any of that data. We've been trying to get with collaborators to try, actually, Tian and Andy in North Carolina have been working on trying to get some of that data so that we can actually calibrate the model properly and determine if our hypothesis is correct, because right now that's just what it is. Yeah.
Okay, I think that those are all the questions for now.
Okay.
Somebody else with a quick question to ask? If not, then I would like to thank you again for your talk. And we can